How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're watching DNA Today, a multi-award-winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor and your host. In this episode, we are featuring a rare genetic disease called Tuberous Sclerosis Complex, or TSC. Joining us for this conversation is Dr. Ian Miller, who is a doctor specializes in pediatric epilepsy and TSC. Dr. Miller serves as the clinical trial medical lead for Marinus. So thank you so much, Dr. Miller, for coming on and teaching myself and, my audience about TSC.
Hi, Kira. Thanks. It's my pleasure.
So I figure we could start with the question that you probably are expecting. What is TSC? Did I pronounce it right, first of all, to make sure I'm getting the pronunciation right? Because in genetics, we call things by acronyms a lot. And then you're like, hold on, how do I pronounce this word again? So give us a little bit of a background as we start this conversations for people that may not be as familiar with the disorder.
Yeah, you nailed it. It's tuberous sclerosis complex, and it is a genetic disease that is autosomal dominant. That means that, of course, one copy is enough if the gene is aberrant to cause the disease. And what's a little bit unique about it relative to other genetic forms of epilepsy is that it has a lot of other non-neurological symptoms. We learned in the early 2000s that the gene associated with tuberous sclerosis is related to cell cycle modulation, and that explains a lot of the phenomenon and the symptomatology that we see in the other organs, such as the skin, the liver, the kidney, the lungs. There are others, but it's multi-organ involvement.
So what are the kind of symptoms that people with TSC have that affect, like you were saying, the skin, the liver? What can come up in terms of maybe during that diagnostic odyssey of symptoms that people are reporting to healthcare providers like yourself?
Yeah, I really didn't think about how those symptoms would kind of play out in terms of diagnosis. But what really struck me and what I realized as I began to take care of more of these kids is that the symptom that started their diagnostic journey really totally affected their mechanism of presentation. It's kind of like the body, when it has a TSC mutation, has multiple modes of failure. And if the first most evident failure is on the skin, that might be what leads you to diagnosis. And so you're if it's the skin that brings you in, that means that your brain is functioning well enough that you're not having epilepsy early on, because skin involvement is kind of later in life. And so therefore, people that present with skin involvement tend to be neurologically less affected and kind of healthy kids that come in and have angiofibromas, usually on the face, because they're somewhat related to sun exposure. And the dermatologist says, hey, we need to look at things like an MRI of your brain, and we need to look at an ultrasound of your kidneys. And obviously that's really shocking to somebody who looked for all the world like they were completely healthy and that this was never suspected by their parents. Compare that to a pregnant couple that has prenatal ultrasound in the sixth month or the 7th month or the 8th month, and they find a tumor in the heart of the fetus. That's terrifying in a completely different way, and is another mode of failure and another mechanism of presentation that's just completely different. And when those kids get diagnosed in utero, obviously there's some really serious, very scary medical circumstances that are unfolding, but they're prepared from the get-go. They really know exactly what they're dealing with once they get up to speed and understand what we know about the disease in 2023. And it's a very different journey for those individuals. And obviously no journey is easy, but they all are quite distinct.
A lot of rare genetic disorders, we see that people have similar paths to finally getting that diagnosis of that odyssey. But it's interesting to hear you say for TSC, that's not necessarily the case, that people can really learn about the condition through a lot of different pathways, and some that are more of you kind of saying kids that their first symptom is more of those skin symptoms, usually on the face because of sun exposure, as you said, that's going to be very different than prenatally diagnosing like a tumor in the heart in terms of someone's experience. To me, I'd think two separate conditions. So it's interesting that the same genetic condition can really present differently in people. Would you say that a lot of dermatologists and, I'm thinking like maternal fetal medicine specialists, OBGYNs, like of the doctors that would be involved in the types of cases you mentioned, would you say that many of them are aware of this condition or not so much because it is on the rare side?
That's a really good question. And to be totally honest, I'm at the same time kind of impressed when colleagues identify these multi-system diseases based on a single, organ system and get them referred to a TSC clinic. On the other side of the coin, however, I guess you don't know for sure how many kids might be missed, right? Because if the professional or the expert in that organ system doesn't identify it, then you don't know what kind of the denominator of that affected population is. So I've been impressed, but I guess I hope that my experience kind of represents the kind of global experience for patients, because obviously all patients benefit from having early diagnosis and kind of prompt recognition of exactly what's happening.
That's a nice way to phrase it and praise those healthcare providers that, are paying attention for that one slide in medical school or graduate school, because, it is a rare disorder.
Tuberous sclerosis itself is relatively frequent. It's estimated to affect about 1 in 6,000 individuals. And so that ends up being a lot of patients and is probably closer to that upper limit of an orphan disease population than other diseases that are kind of ultra orphan or very, very rare.
Yeah, that's certainly more common than a lot of rare disorders that we're talking about on the show. And obviously there's a gap in terms of just like what are ultra rare or nano rare to kind of more rare in that situation. So you mentioned at the top that this is an autosomal dominant condition, so it can be inherited from a parent, but it also can happen randomly. How often do we see one or the other? Is it more common to be inherited versus kind of happening, as we say, de novo?
Yeah, for this disease, it's quite disproportionately inherited, and that's in part because of how diverse the disease presentation can be. We talked earlier about which organ system leads you to presentation. There's one group of individuals that never present in their entire life, and they kind of present, if you will, with their affected child, right? So when you have the baby in utero with the heart tumor, one question is, okay, what does this tell us about, one or the other parents potentially? It does happen spontaneously, probably about 10 to 20% of the time, but inherited is the majority of the affected individuals.
So then you have a lot of families that have multiple people in the family, I would imagine, being affected. Or like you said, a child is being diagnosed and then you end up maybe doing what's called trio testing of testing the parents and saying, oh, actually, this was maternally or paternally inherited in that sense. And that probably is shocking for a lot of parents that maybe had more of the mild symptoms, as you mentioned, but it just went undiagnosed, maybe because they also didn't have severe symptoms that required a lot of medical follow-up in that sense. In terms of, I know we've kind of mentioned like that the diagnostic odyssey can be different for everybody, and that it is really fantastic when healthcare providers do identify, oh, we think that this could be TSC. Are there other conditions that you are meeting with people with this disorder that they say, well, my first diagnosis with this, but it was actually wrong? Are there other conditions that people either commonly mistake for TSC, or is part of that what we call a differential diagnosis list of like, well, we're not sure what condition it could be, but we're thinking like it's one of these on a list?
Yeah. For better or worse, the organ system involvement in the skin, on the MRI, in the kidneys and the lungs, certainly in the heart, is all relatively unusual. There's not a long differential diagnosis for even a single one of those organs, right? When you see them, you're pretty suspicious out of the gate that you're dealing with tuberous sclerosis, from what I understand. I'm obviously not a specialist in those
helpful
diseases.
Too. Yeah, because a lot of
tremendous
like symptoms were like, well, this is very generic, like global developmental delay, autism. Like there's so many symptoms, especially in that pediatric age range where we're like, this could be so many things. Where do we start? So I would think that really helps with the diagnostic odyssey and getting people to you and other specialty clinics and people that can help that specialize specifically with this disorder.
Absolutely. And that's actually kind of one place where I wish we could do a little bit better, because out of all the specialists, you said it exactly, those neurological symptoms before getting the MRI, and sometimes even the MRI can look ambiguous or might not be pathognomonic for tuberous sclerosis, although often it is. But prior to the MRI, the individual may present in childhood with infantile spasms, right? If they have infantile spasms, you're going to find out that they have tuberous sclerosis in short order, but that's not as pathognomonic as some of the skin features are, or a cardiac tumor, for example. If it's not infantile spasms, but is a less severe form of epilepsy, maybe later in life when they're 2 or 3 years old, a lot of times they'll have a first-time seizure, and sometimes the parents won't recognize it because these focal seizures may or may not be overt. So it's possible that the kid would have kind of a funny look on their face. They might have a little bit of a color change and maybe be unresponsive for a few seconds. That could be a seizure, but it's understandable why not every parent would, say, hey, that's a seizure and I need to go see my doctor. It just looks kind of innocent but weird. And so in those cases where you have a less severe form of epilepsy, I've seen those kids have their diagnosis delayed because the MRI is subtle, because they don't have a lot of tuber burden in the brain, or for other reasons. There's a lot of reasons. So it really highlights the importance of having a genetic diagnosis for every individual that has epilepsy.
Yeah, that is very helpful, especially because there are so many genetic conditions where epilepsy is a symptom of that condition.
Precisely.
And for people that are diagnosed with TSC, at that point, is there anything that we can do in terms of like prevention? Like I'm thinking as we're talking about seizures, is there certain medication that tends to be better for, kiddos with this condition, or if people are adults being diagnosed, as well as like the other symptoms? Because we can't necessarily, change someone's genetics, at least at this point in time, 2023. We'll see how CRISPR develops. But in terms of preventing more of those symptoms that are coming up or helping to treat them, what does that look like right now?
That's a great question. And I can kind of address 2 parts of it. The first is kind of the pathophysiological mechanism of this TSC1 or TSC2 gene being dysfunctional, and the other piece being kind of the symptomatic treatment of the seizures, which globally are probably the most burdensome and scary and awful part of the disease for individuals that have them. Not everybody with tuberous sclerosis does. So from a disease progression standpoint and from a disease modifying therapy standpoint, I feel like tuberous sclerosis is just a poster child for the value of basic science and kind of serendipity in medicine. And that's because when the gene was identified as TSC1 or TSC2, it was rapidly understood that affects mTOR. mTOR used to be called the mammalian target of rapamycin, and they've changed it to, I think, the mechanistic target of rapamycin just to keep the acronym the same, and they realized it wasn't just in mammals, it was in earlier organisms also. But the point is that we had medications in our formulary that were already approved by the FDA for other conditions, which were known to affect mTOR and work through an mTOR pathway. So when that happens, it's just a phenomenal opportunity to use a medication. You don't know how effective it's going to be in this new disease. You know that it was effective in this case for immunosuppression for organ transplantation, but you need to find out whether it might be effective in the disease state of interest. But you have a lot of information in your hand already about the safety profile, right? Because people that are having immunosuppression are not only trying to replace the amount of mTOR inhibition that a healthy person has, they're trying to go above and beyond that and really super physiologically inhibit the mTOR function. So it's kind of a perfect opportunity. Not only do you have a medicine that you have a well-characterized safety profile, but probably your safety profile is going to be even better because you're not going as far. You're simply trying to replace what's missing rather than really bearing the needle and stopping all mTOR function, for example. So if that makes sense, it really kind of characterizes and gives you a little bit of a sense of the excitement and the opportunity that turned out to be well-placed. We now use everolimus and sirolimus as mTOR inhibitors as disease-modifying therapies in tuberous sclerosis.
Yeah, it's such a fantastic experience, and I haven't worked directly in pharmaceuticals, but when there's already a drug approved for that mechanism and it's for something else. You're talking about immune suppressant for people that have received an organ, and it's not going to be there unless it's from an identical twin. You're going to have some differences there, and to make sure that your body's not fighting that as like foreign object kind of thing. But it's such a great thing in medicine where we realize, wait a minute, we've already developed this drug that affects this certain cellular pathway. We could use this in other conditions where that same cellular pathway is affected. So, kind of brought me back to cell biology and taking that, probably 10 years ago now. But, mTOR, I think it's like little m, big T, O-R, right?
Exactly.
I'm picturing it in my textbook.
Nailed it.
But that's such a great thing. And I would think that early intervention and management are really crucial in this, because if there are certain medications like, this concept you're mentioning with this medication, if that is helpful for someone, I imagine if they're diagnosed earlier in life, that maybe could you prevent certain symptoms from happening? Or is it more, we see a symptom coming up, let's treat that symptom? Yeah,
that's an answer that's not yet known. We do know that the medication is disease modifying in terms of skin progression. In the old days, once the individual with tuberous sclerosis had this complication, like the angiofibromas of the skin, or maybe what's called a subependymal giant cell astrocytoma. It's a big mouthful that we abbreviate as a SEGA, S-E-G-A, as a tumor in the brain that can actually grow. Once that grew to a certain point, you had to have surgery to treat it. Now, with mTOR inhibitors, we can actually shrink some of those tumors and make that progress regress. So it's just a completely different universe for the non-epilepsy manifestations. So I kind of promised you I'd touch a little bit on the epilepsy piece, and mTOR medications do help with seizures, but they are far from a perfect treatment for everybody, like they almost are with some of the other organ systems. So mTOR inhibitors are used, but we also use kind of traditional or conventional seizure medications in order to treat the seizures. And probably about 75% of individuals with tuberous sclerosis respond to those seizure medicines and have complete or almost complete control and kind of don't need to explore other options. But the way that I would say it is that, conventional seizure medications and mTOR inhibitors are kind of plan A for individuals that have epilepsy due to tuberous sclerosis. But about a quarter of the individuals still require kind of plan B as an alternative to explore and need to think about other options.
And we've talked a lot about what symptoms come up, how we are treating them, in this moment of what doctors and other healthcare providers are providing patients and different guidelines and all of that. What about in terms of the patient experience of like how that affects someone if they are having seizures or some of the other symptoms and features you mentioned? Is the skin findings on the face more aesthetic, or can that cause a medical issue down the line? Like, what is kind of that patient experience, and from you meeting so many people that have this condition, in terms of just how it impacts their life, and if there are, certain aspects that kind of need to be a little bit different than someone that doesn't have the condition?
Yeah, all of the complications of tuberous sclerosis can be incredibly burdensome. And to kind of answer the question about the facial angiofibromas specifically, they are almost completely aesthetic. They could, impair shaving or something like that in a male. But if you think about it, your face is what everybody sees and identifies you with and relates to, and it's kind of your first impression that you make with everybody. And so even small amounts of angiofibromas really make people self-conscious, right? Even if it's not something that is on the top of somebody's mind who meets them, it still affects their self-confidence and their self-impression and everything, the way that acne does. Most human beings, I think, have acne as a teenager, and even though you kind of look at it and think, oh, no big deal, it doesn't affect your overall health and your overall well-being, it's a huge deal to every teenager that has it. And imagine if that was with you every day for the rest of your life. It just is a really unfair thing that these individuals have to deal with. And that's just one of the, list of, organ system complications that is just frustrating to deal with and chronic in its, in its timing.
Yeah, no, that makes sense. I think that's well said, and that taking a look at that holistic perspective of how is this affecting this person, and not necessarily just the strictly medical aspects to that. I think it's important, as I'm also a healthcare provider in genetic counseling, and it's just really helpful to be looking at it, as someone, as a complete person, and seeing all the different aspects that it affects in their life. And I think looking at what we have is fantastic, but there's a lot in the future in terms of, with the organization you're with, Marinus, of the clinical trial that you guys are doing for TSC. So I would love to learn more about the study. I mean, what phase is the clinical trial in, and the purpose, and kind of just starting to dive into that aspect.
Yeah. So to kind of put it in context of what we've previously covered, I mentioned that traditional seizure medicines and mTOR inhibitors are kind of plan A for individuals that have seizures due to tuberous sclerosis. So that kind of opens the door to the question of what's plan B. And there are kind of 4 universal possibilities for people that have epilepsy that didn't respond to the first 2 medications. Those are the people for whom plan B is necessary. Those 4 options are the ketogenic diet, the vagus nerve stimulator, or some other form of neurostimulator like the responsive neurostimulator called Neuropace, epilepsy surgery, if all of the seizures are thought to come from a single part of the brain that can be safely removed and therefore potentially cure the seizures. And then the 4th are investigational medications. So the trial that Marinus is sponsoring in tuberous sclerosis falls under that 4th category of plan B options, meaning it's an investigational medicine. It's not yet proven to help individuals that have epilepsy due to tuberous sclerosis, but our research hypothesis is that it can and would, due to the mechanism and due to the pathophysiology of tuberous sclerosis, et cetera. And we are sponsoring a trial in order to try to measure that scientifically in terms of documenting whether that hypothesis is correct or not.
So what led you and your team to say, we're going to focus on TSC and not other conditions that are maybe similar to it? Because it is a condition where we have different treatments available. So I'm wondering, what went behind the scenes in terms of let's focus on this condition, and then how this treatment is thought to maybe it will be different and really enhancing people's lives and being able to treat a lot of these symptoms.
Yeah. So in order to answer that, it might help a little bit to provide a brief understanding of kind of the mechanism or the putative mechanism of action for ganaxolone, which is the medication that we're studying. Ganaxolone is thought to act on the GABA receptors in the brain, which are one of the primary neurotransmitters that kind of tone down or depress brain activity when it's activated. There are other GABA agonists that we are familiar with. Probably the most familiar one to humanity is alcohol. Alcohol has a GABAergic quality to it and acts by essentially increasing GABA tone. But there's a lot of other pharmacological medications that every doctor is familiar with, which are the benzodiazepine family of compounds and kind of the barbiturate family of compounds. Those are also kind of stronger central nervous system depressants that work on GABA. So the point is, ganaxolone is thought to work similarly to those medications, but it is also unique because it doesn't work simply inside the synapse where the sending brain cell terminates and communicates to the receiving brain cell. It also is thought to work extrasynaptically, where GABA receptors are thought to be more modulatory in terms of long-term regulation of receptor expression. So that's a really complicated model that we've just drawn in 3 sentences. But the point is that there's reason to think that ganaxolone may have, a different profile in terms of long-term behavior and efficacy than some of the conventional medicines that only work intrasynaptically. So medications that work on GABA tend to be broad-spectrum anti-seizure medicines. There's not anything about it that makes us think that in tuberous sclerosis uniquely this will be effective. There actually has already been a phase 3 trial in a disease called CDKL5 deficiency, which of course is deficiency of the CDKL5 gene. The ganaxolone trial in CDKL5 deficiency is completed and has been approved. So that was kind of our first proof of concept, if you will, that this really is a reasonable hypothesis for GABAergic tone in general. But then the question of why tuberous sclerosis makes sense as the next genetic epilepsy to study really relates in part to kind of how significant the need is. Their seizures tend to be very severe, and there's definitely a large population of patients that need this medication by virtue of how common the tuberous sclerosis gene mutation is. But also, we really benefit from kind of the social organization within the tuberous sclerosis community. There is a patient advocacy group called the Tuberous Sclerosis Complex Alliance, and they've been active for 40 years in this disease space and are kind of the model that everybody aspires to be in terms of patient advocacy, because they've been so successful and they're so effective in terms of their judicious use of resources and organization and everything else. So by interfacing with the tuberous sclerosis population, we are able to work with the Tuberous Sclerosis Alliance, who can help us disseminate and make people aware of the fact that the study's going on, the value proposition behind it, and hopefully get people excited about participating.
Yeah, that's wonderful. And just that you've been able to look at, well, how can we make this better in terms of the long-term aspect too, that it sounds like the medications that are available today to be prescribed to people with TSC are a little bit more of like working in a short term compared to this potential drug that could be really helpful of saying, well, this could work more in a long term, of just like how long that, which we'll see if I get this right, how long like the neurotransmitters are kind of like out there and then can be taken up by these receptors of the GABA receptors. How close was I? Did I get it close?
Pretty close. I think thankfully, I don't want to kind of not give conventional seizure medicines insufficient credit. They work long term for the fortunate 75% of patients that they're effective for, right? So there's a big pool of patients that are benefiting today and shouldn't change anything because they don't need to, and that's awesome for them. The problem is that with all of our conventional seizure medicines, they have the same chance of working, essentially. Their effectiveness rate is relatively comparable, even if the doctor kind of pulled them out of a hat and prescribed them random, right? And that's never what the doctor does. They try to be careful about what side effects are least and, convenience of administration, et cetera. But from a pure effectiveness standpoint, they're almost exactly the same in terms of having about a 75% chance of working. So one would think if you know that there's an equal chance of about 75% chance that they'll work, and if a person knows that we have 20 or so seizure medicines, one would reasonably conclude that there's not going to be anybody that still needs more, because you have a 75% chance, and if you're unlucky enough not to respond to that first medicine, the second one should have a 75% chance, and so you're going to end up with 25% of 25%. And if you take 25% of that 20 times, you're going to end up with this teeny tiny little, grain of sand of needy patients. The problem with that line of reasoning is that the seizure medicines tend to help the same group of patients. So by the time you're prescribing the second seizure medicine, it's not 75% anymore. It's profoundly undercut by the fact that you didn't respond to a seizure medicine. Therefore, your second medicine probably only has about a 10% chance of working. Obviously, scientifically, we call that a dependent relationship between the effectiveness rates, and the dependence, or the effectiveness rates in epilepsy are highly dependent. So by the time you fail the second medicine, your third medicine has about a 1% chance of really profoundly helping you and making you seizure free.
Wow, that's very low.
It's awful. And it's a lot of families, say you're presenting with epilepsy as your first, entree into the medical system, right? It's so unfair because parents assume that in 2023, that doesn't happen. They think that in 2023 we have medicines for something as, frustrating and simple as epilepsy, right? That doesn't seem like an unfair expectation. But the fact is, for a ton of patients, our conventional seizure medicines don't work. So that's where the Plan B options and research medications and ganaxolone comes into play. And to kind of modify or polish slightly the discussion about the mechanism and how we think about its effectiveness, we know that for currently available GABA agonists, right, medicines that tickle that GABA receptor, the way that the GABA receptor responds to them is by activating, but then endocytosing and being pulled into the cell. So it's no longer at the cell membrane. Well, guess what? If your GABA receptor is no longer at the cell membrane, you have less receptors, and therefore it's harder to hit and have the same effect with the same amount of GABA agonist. So it is the possibility that we might not have the same amount of endocytosis and the same amount of long-term blunting of therapeutic effect, it's not that the medicine is wearing off or metabolism is changing or that there's less neurotransmitter or benzodiazepine in the brain. It's that it's there, but there's nothing for it to
like grab onto and take
have
in
the physiological effect.
Wow.
Exactly.
Okay. Interesting. And so for people that want to learn more about participating, maybe they have TSC themselves or a child or a loved one, or maybe they're a healthcare provider listening saying, oh, I have a patient in mind, someone with the condition. Where can they learn more about this to either be, working with you directly, Dr. Miller, or just, being involved in the trial?
Yeah. So there's a website called trusttsctrial.com, and that's all you need to put into your web browser to get to the right place. And it has an overview of the study, including some of the basic requirements for inclusion and exclusion. It's not exhaustive because there's a lot that tend not to affect a lot of people, and so they're kind of important for your individual provider to go through with you. But there is the outline of kind of the important eligibility requirements, which include having tuberous sclerosis. The other one that's really important is having 8 or more seizures in a 28-day period. We have to have a certain minimum number of seizures so that if there's an improvement, we can actually show that it's going down. If you have 1 seizure a year, it's easy to imagine that you can't show an improvement when you study it for 20 weeks or whatever. On that website, trusttsctrial.com, there is also a map which shows participating study sites that has contact information. There's also a form that individuals can fill out if they simply want to engage with the medical affairs group that will put them in touch with somebody, or if they want to talk about, the opportunities at different sites. And importantly, if a site on that map isn't available close by, because it's a sponsored clinical trial, there's actually the possibility to have travel paid for the patient and a care provider to go with them to the study site and participate in the clinical trial.
Yeah, that's fantastic. I hear more and more clinical trials these days often have an aspect where travel can be reimbursed or covered. So that is just great. You're doing amazing work, and I'm really intrigued, and I feel like somewhat invested now to see how the clinical trial goes. Like, will we see that there are less seizures in the majority of people that are, on this drug? So thank you so much for just explaining all of this to me. I think it's very interesting. It's a condition that I've been aware of. I had to study certain things for boards, like the astrocytes. I remember that was one of the things I had to memorize and everything. But, it's definitely very different when we talk about it more in terms of treatment. How's that going? And in terms of like where clinical trials are. So it's really exciting to hear all the work you're doing. And for people that want to check out that link, again, it's trusttsctrial.com. It's also going to be in the show notes. Another place you can go to is norare.com/TSC. But again, all that's in the show notes, so you don't have to remember anything. And we'll include a link to the TSC Alliance as well, so people can check that out. Thank you so much, Dr. Miller. This has been really informative, and I hope that it's really resonated with a lot of people that either have the condition or someone in their family, or healthcare providers to be like, hey, remember this condition when certain aspects, symptoms come up that, it could be TSC. So thank you so much, Dr. Miller.
Outstanding. Thanks, Kira. My pleasure.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.
We're all made of DNA. We're all made of the same chemical DNA.